until we start the panel. So up to you.
Sweet. Oh, I guess I should.
Hi, everyone. Thanks for joining. We'll go ahead and get started. Got a little housekeeping to do. So we'll go ahead and jump in. My name is Alexis Whittam. I'm the Director of Communications for the Colorado Coalition for the Homeless. You are joining us for our Education Series 2024. This is the May session on mental health and homelessness. We do these most months on the third Thursday of the month, and we cover a topic at the intersection of homelessness and another issue that relates to it. So appreciate you all coming and making time today. Next slide, please. So we'll start off with a little housekeeping. Zoom captioning is available. If you just want to go down and hit the little CC, it'll show you captions. They are auto-generated, so they may not be perfect, but hopefully they will assist you. And then, of course, if you happen to be someone who's watching later, we're going to put this on YouTube. You can always use YouTube captioning there as well. Let's talk about our format. So we are doing a panelist format today. This is the typical way that we run these. We do a little introduction with data points. My colleague Andrew West is going to handle that in just a minute. And we talk about the topic and important things you need to know, just like a 5-10 minute overview to understand sort of the data, the background. So we're all on the same ground as we go and jump into it. Then we have a panel with experts in the field for about 45 minutes. We have pre-planned questions for that. And then at the end, we do a Q&A. So if you are joining us tonight, please put questions in the Q&A. We'll have about 15 minutes at the end to answer any of your specific questions as well, anything that doesn't get covered in our planned time. If you're here, also please introduce yourselves in the chat, meet each other. We know we get just community members here who just want to learn more. We also get people who work in the sector and may want to connect with each other. So please introduce yourselves, connect in the chat, learn more. And but just FYI, it's in webinar format. So I'm on camera, our panelists are on camera, everyone else is off camera. So you do have to use the chat in order to connect. And your cameras and microphones will be off while ours will be on. The session is recorded, as I said. We put it on YouTube usually a couple days after the event. And that way you can share this. You can go back to parts you want to see again. People who aren't able to attend today can see it later. And we do send out the slides in our follow-up email to this. So if you're interested in the data, don't feel like you have to take notes, just sit back, learn, and then we will send the slides out at the end with all the data and the sources to it. If you want to be on two screens and share on social media during this event, something that catches your eye, or see what we're tweeting out or putting out, I guess Xing out, who knows how you say it these days. We are at Co-Coalition. There's also the other organizations tonight also have handles at co_mental health and at We Are Wellpower. And then you can also use the hashtag CCH Ed Series. So with that, I'm going to hand it over to my colleague, Andrew West, who's going to do a little bit of an introduction about mental health and homelessness.
Great. Thank you so much, Alexis, for kicking us off and getting things started here. Hi, everyone. My name is Andrew West, and I am the Policy Associate with the Colorado Coalition for the Homeless. I'll provide a bit of a data overview, specifically touching on issues of mental health and how they are related to people experiencing homelessness and the broader crisis that we're seeing. But first, I want to level set a bit and identify that this is situated within a much larger crisis of mental health across the country. This is not something obviously specific to people who are experiencing homelessness. And I think probably a lot of this is not news to you, that we are in a crisis of mental health issues across the country. 2 in 5 adults currently report symptoms of depression and anxiety. and over a third of Americans live in a community with a shortage of mental health professionals. Less than half of Americans with a mental health condition are receiving treatment. So we both have a lack of available and appropriate treatment for folks, as well as an increase in the number of people who are needing treatment. There is a higher prevalence of mental health conditions among men than women, generally, and in some of the studies that we looked at, that is cited in this report. But Black and brown communities as well are disproportionately undertreated. So important to note that this is not something unique to people experiencing homelessness, and is part of a much broader crisis. But now we will turn to mental health and its implications for people who are experiencing homelessness. We know that there's a strong relationship between health and homelessness is correlated with a host of negative health outcomes. It's important to note that this is a bidirectional relationship, meaning that mental health can be both a cause and a consequence of homelessness, meaning that poor health can often precede and contribute to homelessness. Some people have health conditions that prevent them from working, and mental health issues can make it really difficult to maintain housing, employments, relationships, and other things like financial security that allow one to stay outside of homelessness and can contribute to experiences of homelessness. But in addition, once someone becomes homeless, it can lead to mental health conditions or exacerbate existing ones, which can make it harder to exit the cycle of homelessness. And I'll note that this is the case for health issues broadly, not just mental health. And I would recommend folks check out our health and homelessness report that we released in 2023 for more info on that. Next slide, please. Thank you very much. I'm going to give a bit of an overview of sort of the numbers here and estimates of mental illness within the population of people experiencing homelessness, with the caveat that estimates of prevalence vary pretty significantly. The first couple of numbers here we have are from Colorado point in time count data, which is a annual count that is done on one night, usually in January, where the population of people experiencing homelessness are surveyed and asked a bunch of questions on demographics. And that's sort of how we have a snapshot and a picture of what the state of homelessness looks like in Colorado. From the most recent 2023 data, we don't have 2024 data yet. 27% of people report a severe mental illness, and that's just the terminology that is used in the report. And that's about almost 4,000 people out of the 14,000 people total that are experiencing homelessness in Colorado. Point in time count nationwide shows similar numbers, about 21% of people experiencing homelessness who report a severe mental illness. Next slide, please. And here's a bit of a snapshot of that data over time. Again, this point in time data is only one metric that we look at. And we know that this is actually most likely an undercount of folks, because it's literally going around looking for people who are experiencing homelessness, and can be more of an observation than a true representation of what the population looks like. But we have seen a slight uptick over time, but this is helpful to see just sort of what the numbers are that we're looking at. With, again, the note that in 2021, we only conducted a sheltered count. So people who were experiencing unsheltered homelessness were not counted that year due to concerns with the pandemic. And a little bit more on the numbers here quickly. There are a few studies that are often referenced. One study with over 50,000 participants revealed a lifetime prevalence of 77% of a mental illness or a mental health disorder, according to the study, and 67% current prevalence. And the most common mental health disorders in that study were substance use disorder, antisocial personality disorder, depression, bipolar disorder, and schizophrenia. I'm sure we'll hear more from our panelists and a bit later in the presentation on specifics about these conditions. But those are the sort of conditions that we're talking about. Another study found approximately 71% of people experiencing homelessness had a probable mental illness or major psychiatric distress. That one looked at specifically populations in the US. And the last study looked at higher income countries, so not specifically the US, and found about 3/4 of people have some mental health condition while experiencing homelessness. So again, we've got a pretty wide range of estimates of the numbers here, but I think it is helpful just to situate us as we begin this conversation. And next slide. I wanted to point out a quote that I found from that first study that was mentioned of 50,000 people, that provides a bit more context to understand the data that I think is also helpful to get us ready for our panel here. This is from one of the professors of medicine who wasn't directly involved in the study, but was quoted in a report or in an article on the study, who highlights that in a city or community where housing is very expensive, there's not enough for everyone to be housed. There is a lot of competition for housing, and there's not enough affordable housing for a number of reasons. We know that people with mental health conditions and substance use disorders will be among the first to lose their housing. And he goes on to say it's not because there are fewer people with schizophrenia in those areas, it's because people with schizophrenia are treated differently. The rate of homelessness is determined not by how many people have that condition, but by how we treat those people and how we set up our society to either support or to not support people who have disabilities. So I thought that was a good way to humanize the data and give a bit more context that this is not something that we have people who have mental health issues all over the place. And it's just a matter of how we set up systems. All right. And I mentioned briefly some of the mental health conditions that were specifically referenced in the study. But some of the common ones that are talked about are alcohol and substance use disorders, bipolar disorder, depression, schizophrenia, spectrum disorders, personality disorders, and anxiety disorders. It's also important to note that many people who are experiencing homelessness can have multiple conditions and other comorbidities. So conditions more related to physical health that can exacerbate conditions of mental illness. But as well, I wanted to highlight that, again, the experience of homelessness itself can be sort of viewed as a health condition. There are just so many negative health outcomes that are associated with homelessness. And we know that that experience itself can exacerbate a lot of these conditions. So now we've talked a little bit about what these conditions look like, what some of the numbers look like. And as we start to move into solutions here, one of the main barriers that we talk about is treatment. There's a lot of barriers to treatment, in particular, again, for a lot of people in the country, we just don't have enough treatment, but there are especially barriers for people who are unhoused. And mental health issues can be also difficult to treat while unhoused. Being unhoused can significantly interfere with one's ability to seek out care and maintain treatment just because there's so many difficulties in managing all of the immediate needs and surviving on the day-to-day while also trying to seek out appropriate care, trying to store medication. We know that non-compliance with medication and taking that regularly can be high because a lot of people just don't have a place to store it or don't have a regimen in place just because of how difficult it is to be unhoused. In addition, there's a lot of stigma that continues to pose barriers to care. People might not want to seek out care or fear that they might not be able to access other resources if they admit to having a mental health condition, which is, again, one of the problems that we see in collecting data and having good estimates of the numbers of people who are experiencing these conditions. And according to Mental Health America, Colorado ranks last in the nation in access to mental health care, specifically for adults. We're doing a little bit better in care for youth, according to their measure, but last in the nation is pretty abysmal for adult care. And again, it's worth mentioning that children and families who are living in poverty, in addition to Black and Brown communities, are the least likely to have access to this much needed care. So I'll give a bit of an overview of what works. What are some solutions? This data presentation can be a little discouraging at points, but we like to offer solutions as well. And the panel will give a lot more of that. But we know that we need to invest in affordable housing. At the coalition, we know that housing is healthcare, and that by providing housing, that provides an anchor that people, an anchor and a foundation where people can build upon that and address health conditions. So investing in affordable housing is the key thing to remedying the crisis of homelessness and will help improve mental health conditions as well. It's important that housing first, the approach that we take is not housing only. So we want to expand access to mental health services that have low barriers, that are easily accessible, not stigmatized, and reject approaches that want to use involuntary treatment, civil commitment systems, and provide cuffs and criminalize people with mental health conditions. This is something that we have seen making a bit of a resurgence, I think, in national policy conversations as well as at the state capitol. This idea that having a mental health condition is a crime or that it's some individual failure, that it's something wrong that someone has done, and that we can funnel people into treatment through the criminal justice system. It's really important that we provide care, not cuffs. And those wraparound services that I mentioned before, like mental health and behavioral services, substance use treatment, harm reduction resources, all these things that we do at the coalition. Next slide here. One specific program using the Housing First approach is Denver's Social Impact Bond Initiative, which was implemented in 2016 and provided supportive housing for chronically homeless individuals who were frequent users of emergency services. So we're talking about things like detox centers, ambulances, jails. And the program found that there were significant reductions just by providing housing. There were significant reductions to emergency service use, and folks had much better access to care while they were in the program. It's worth mentioning as well that those services were provided at half of the cost of these traditional emergency responses. And most participants who participated in the program were not only housed after a year, they were housed after several years of being in the program. And we're really excited that we've launched the SIPR program. I don't exactly have the acronym for that on top of my head. So here we go. Social Impact Partnerships to Pay for Results Act. And we'll hear a bit more about that later, which expands on all the great work done through the SIP program. And next slide here. Another thing that we'll talk about is the Support Team Assisted Response, or STAR program, which is an alternative response team that was launched in June of 2020 that includes behavioral health technicians to engage people who are experiencing crises related to mental health, substance use, and homelessness, and make sure they get behavioral health treatment and that sort of approach rather than having police presence. It's a trauma-informed approach that seeks to de-escalate, provide resources, make connections, and provide care for people rather than looking to criminalize these experiences. And this program has been enormously successful and is a model for other cities throughout the country. They've responded to over 8,000 calls. 41% of individuals who were connected to the program received formal treatment, and then 28% were transported to another resource where they could receive treatment as well. So again, these are all innovative solutions that at the coalition and a lot of our partners are working on to sort of change the way that we think about mental health, and instead of criminalizing people, provide access to care and make sure they can get support that they need. All right. And I think that's it for me, and I can kick it back to introduce the panelists.
Thanks so much, Andrew. Appreciate it. Appreciate you covering all that. And yeah, as I said, we're going to send those slides out. So for those who are asking, they will be coming out. I'm going to go ahead and read all of our panelists' bios. We are having trouble with a couple folks getting connected. So we may just be doing this in a fun little different order where I read everyone's bio and then we start with Tony and Sam, and then our other two panelists join as we get going. So thanks for bearing with us. You'd think after all these years of Zoom, we'd have it all figured out, but never a dull moment. So for the bios, Vincent Atchity is this executive director of Mental Health Colorado. Mental Health Colorado advocates for every Coloradan who experiences a mental health or substance use condition. The organization engages policymakers, providers, the public, and the press to promote mental well-being, ensure equitable access to mental health and substance use care, and end discrimination. Atchity previously served as executive director of the Equitas Project, a nonprofit that worked with the mental health and criminal justice system. So welcome to Vincent, who is joining shortly. Next, we have Tony Burns, who's on now. Thank you, Tony. Tony is team lead for the SIPRA program at the Colorado Coalition for the Homeless. The SIPRA program is a 7-year research study operating as a modified ACT team. We'll tell you more about ACT as we get going, providing wraparound supportive services to clients who have had engagement with jails or emergency rooms up to 6 times within the last 2 years before randomization into the program. The program focuses on supporting clients dealing with dual diagnosis, substance and mental health disorders. Tony manages cases of more acute clients and supports the program manager in reporting qualitative data to research partners. Samantha Ravens, who's on with us, has been a licensed clinical social worker with WellPower for the past 11 and a half years. Her specialty is working with people with severe and persistent mental illness and dual diagnosis, specifically in a crisis setting. As the Associate Director of Criminal Justice Services, Samantha oversees several WellPower teams that help divert individuals from the criminal justice system and/or reduce recidivism, including co-responder and support team assisted response STAR programs, as well as WellPower's court-based teams, competency diversion, competency restoration, bridges, probation liaison, and behavioral health navigator, and WellPower's court-ordered assertive community treatment COACT team. So welcome, Samantha. And finally, Josie Sullivan, who will be joining us shortly, has worked in the field of psychiatry for the past 16 years and at the Colorado Coalition for the Homeless as a psychiatric nurse practitioner for the past 6 years. Josie works with an integrated healthcare model at the Stout Street Health Clinic, providing both urgent and long-term care to individuals with psychiatric disorders. Her treatment considers the individual's economic and housing circumstances, medical conditions, and substance use disorders. Her philosophy of service is in line with that of CCH and focuses on trauma-informed and recovery-oriented care. She is passionate about improving access to psychiatric care for some of our society's most vulnerable. So, welcome to Josie. All right. So,
thank you.
Awesome. Oh, hey, Josie, you made it. I'm so excited.
I made it.
All right. Awesome. We're getting there. So the first thing we do, and I take this with a grain of salt because not everyone was here for our data presentation, but we always like to start by asking the question, what did you find in the data presentation? Was there anything that surprised you? Is there anything that's missing? You know, as we jump into this conversation for somebody who doesn't work in the sector, is there anything that was missed that we need to think about? And that's for anyone.
I think something that stuck out to me, definitely, and that Andrew highlighted, was kind of the new shift that we've had recently, at least in Denver, with the STAR program, and kind of not cuffs and trying to get people treatment instead of just giving them cuffs. I think that really stood out to me. I think that's so important, kind of as we go through this panel, just to keep in mind.
I can add to that too. Thank you for saying that. I jumped in very late, so I apologize. I didn't hear some of the data. We're having technology issues. But one thing that I did jump in here is that mental health historically has been criminalized. And it is absolutely something that our teams over at WellPower, including the STAR team, really are trying to prevent, right? Our jail is our #1 mental health institution, and that is not a space of recovery for individuals, right? And so we are trying to divert people out of the criminal justice system when not necessary, out of the jail system when absolutely not necessary, and into supportive services. So I really love that you brought that up in this space.
Awesome. Great. Well, I want to start with Josie, ask you a question. As a mental health nurse practitioner at the Colorado Coalition for the Homeless, you're working directly with clients day in and day out. Tell us more about how you do that and how integrated healthcare is part of that and applied to your day-to-day work.
Sure. So integrated care kind of utilizes a team-based approach where there's people from many different disciplines. And where I'm at the coalition, everyone's on a suite and it's kind of pod-based. And I sit with other medical providers. I sit with therapists, dental, pharmacy, nurses, and everyone is sort of working together. And really, I think that that's probably the best model for our patients, because when you think about how difficult it can be just to make a doctor's appointment, think about trying to make that appointment if you don't have a phone or you don't have a car. And so once they make it to the clinic, it's sort of this window of opportunity of how much can we get done for this person. And when they're coming to a clinic like ours where they can get all those services and people are working behind the scenes to make sure that they can get them, and sometimes even all on the same day, it's really, I think, probably the most effective and patient-oriented approach. And that's what's kept me for so long at the coalition, is just because I feel that the care is good, but I also feel that I can offer the things that I can't. So I can offer mental health services, but when it comes to wound care, they can see a nurse. And, if there's housing concerns, I can refer them to a case manager. And so I just feel like it's the best way to get all their needs met.
Awesome. Thank you. And I give tours at the Stout Street Health Center sometimes, and that's what is really cool. I'll be doing a tour in dental, and the folks in dental will say, hey, yeah, maybe someone came in because they had a toothache. And if I can get them to then check their blood pressure and maybe talk to someone about mental health, it's like it's so hard to come in once they've come in, to be able to see if we can help them in other ways. It's just awesome. So thank you for explaining that so perfectly. Tony, even more integrated, I would say, is as a case manager. So you work on site at one of our buildings at the Renaissance Legacy Lofts, as a case manager, and you're sort of working with our clients in that CIPRA program that Andrew mentioned previously, and it is rather complicated. So I know that you can't, I think we could spend the whole webinar explaining the CIPRA program, but like, tell us how you're serving clients in your role as a case manager at CCH, and then sort of how mental health care is part of that service to clients.
Definitely. So yeah, just to provide a brief kind of background, like Andrew was saying, the SIPR program is kind of an extension of SIB, and we're focusing more on the healthcare side. So people who have had engagement with hospitals and kind of in and out of hospital systems. So with mental health, we see people are continuously just going back and forth from the streets to the hospital, to the streets to the hospital, and there's no really bridge there to really get them those resources. So every day we're really seeing clients with some of the most acute symptoms kind of in the state and in the city. And really we see mental health. Sometimes I could be going to get an ID for a client. The next hour I could be de-escalating kind of a mental health crisis. So that's kind of why I love what Josie was saying about the clinic, where we have so many different disciplines there, and when they walk into those doors, they're able to really access so many different resources. We operate as a modified ACT team, so we're really able to offer therapists, case managers, nurses that go out into the field. So we like to really kind of like bring the clinic out into the field and offer those services where the clients may not have them all the time. So yeah.
Awesome. I feel like as a moderator, this is as well as it can go, because you just said like into the field, and now I have a question for Sam about going into the field. So killing it. But Sam, you're working in these outreach programs for WellPower. Can you tell us more about how WellPower is going out and responding to mental health crises and helping people through like co-responders program and STAR?
Absolutely. So I'll start with a very brief history of both of our programs. We started our co-response program back in 2016. Our co-responder model in Denver County is to partner a licensed mental health professional with police officers to provide a more trauma-informed, better response to individuals who are experiencing a mental health or behavioral health crisis. We do lots of training in the mental health world. Police do not do nearly as much as we do, right? And so it's our goal to make sure that when we contact someone who is calling 911 because it's their worst day, or someone's calling 911 on their behalf, no matter the circumstances, that we're diverting them to the appropriate resources in the community, or back to their care professionals that are already working with them that maybe they've disengaged from, or connecting them, generally speaking, to new care professionals if care professionals they had previously weren't working for them because their lives have changed and they need different support. So we originally started partnering with Denver Police Department in 2016. Since then, our co-responder program has expanded to all first responder agencies within Denver County. We're with Denver Police, Denver Fire, Denver Sheriff, where we're on evictions and sheriff pickup orders for individuals who are involuntary committed or on those court-ordered certifications. I think we're the first in the country with the Parks and Rec Department, so we go out with the park rangers. We're with RTD, so we go out with RTD Transit Security and Police. Or with Auraria Campus Police Department. So we are really trying to make sure that we are involved with every first responder agency. So every single person who's in crisis gets a contact from a mental health professional when they need it at the time that they may need it most. We also have case managers that are involved with our co-responder team. So we don't want the crisis, if we respond in a crisis and we give you necessary resource information, or we do have to, talk about hospitalization or anything like that, we don't want to just disappear and say, all right, we're out. That's all you get, right? We want to do that soft handoff because we know people in crisis When I'm in crisis, I don't hear all the information that's said to me. And so we want to make sure that there's people that can help support you beyond just that crisis moment, because that crisis might extend beyond just our point of contact. As we developed our co-responder program, we also realized that a lot of the calls that we were going on, specifically with police, fire, sheriffs, they weren't necessary on those calls, right? There's a lot of calls that come through the 911 system where police are absolutely not needed. If there's a houseless individual who is in the community and a community member is worried about them for X, Y, and Z reasons, if they're not committing a crime, or even sometimes if they are committing a crime, police aren't needed, right? There's more likely a need for a resource connection, or maybe just a resource in the moment, like some new clothing or some food or some access to bus passes, or even just a ride to a supportive service, right? And so we went out to Eugene, Oregon and looked at the CAHOOTS program and modeled our STAR, support team assisted response, off of that program and implemented that in June of 2020. Our STAR program, we have multiple program partners in our STAR program. So WellPower works collaboratively with Denver Health to provide the initial response or the VAN team, where a mental health professional and a paramedic or EMT respond to calls that come through our emergency response system. We also have a dedicated STAR line for that. And they go out and handle the calls where we don't need police on them, right? And we are trying to divert individuals away from that police contact or that other first responder contact. And again, providing them resources in the moment, long-term care, and necessary crisis trauma-informed contact. We also have our STAR partners. We have Servicios de la Raza that provides all of our wraparound services. So after that crisis contact, we're able to refer to them. They work with the STAR Coalition, which is a group of BIPOC-led community members that also provide services to individuals contacted by STAR. We also work with Denver 911 and our STAR Community Advisory Committee to have community input.
Thank you so much. That was such an amazing overview. And I know that later we'll touch more on some more details of the STAR program, and just really appreciate you covering all that. Vincent, thank you so much for joining. Want to talk a little bit bigger picture now. So all three panelists that we've talked to so far are working pretty directly with clients and working within these local systems. What you all are doing over at Mental Health Colorado is working on sort of more broad transformative policy changes that we know are at the heart of solving the homelessness crisis in general, but also mental health crisis. Can you tell us more about sort of the legislative efforts that you all are working on to impact change?
Sure. Thanks so much for having me. So Mental Health Colorado, most of our work on this is at the state capitol, and actually most of our work is more focused on access to healthcare and services and supports, and incidentally housing, but housing has not been our primary focus. But a lot of it is just the recognition that we've got this set of conditions where people who might benefit from early intervention and supportive care that would enable them to persist in a more stable setting don't have that. We have lots of closed doors when it comes to early intervention for folks that end up experiencing houselessness. So we try to close up those gaps, which are tremendous, because there's pretty much nothing about our entire system of care which was designed with the humans in mind. So
thank you so much. Sam, can I go back to you for a minute and ask a little follow-up on STAR? So I sometimes give these homelessness 101 presentations out to community groups, and I often tell people, at least in Denver, I'm like, just put the STAR number in your phone. Sometimes, people are like, I need to call the police for XYZ reason. And I'm like, do you? Or do you need to call STAR, right? Depending on the circumstance. That's sort of something I've just said. No idea if it's right. Going to ask you now. But also, what do you recommend for people in that moment to help get someone in contact with STAR or with other resources? And also, this one's a little bit harder, but do you have recommendations for people outside of Denver Metro where maybe these resources aren't as available that you've been working on here?
Absolutely. Great questions. So yes, absolutely. STAR can respond via that STAR crisis line. I can put it in the chat in a little bit so everyone has access to it. STAR is a civilian response. And so we do have to keep the safety of not only the people we're contacting in mind, but the safety of our responders as well. And so as long as there's no safety element to it, we can pretty much handle a lot of calls. We work with dispatch to dispatch does all of the coding of the calls, right? The call comes in, even through the star line, it's a trained dispatcher. They code the calls, and we've come up with a pretty extensive list of coded calls that star is appropriate to respond. Sometimes, it may be a call that's coded a little differently, but maybe another first responder agency shows up and they're like, this isn't for us. This actually is a great star call. They'll tap us in, we'll give a high five on the way out, and we will take it on from there, right? So, what we encourage is if there's no safety element for sure, don't be alarmed, call that star line and we can come out and respond to you. If you're not sure, it's not, we don't want you to put extra stress on you when you're in a crisis situation or extra stress on anyone having to make that decision. We work with Denver 911 communications, again, to be able to make that determination to see who's the best response. If you're not sure, just call non-emergency line and let them know what you need, and they can make the best determination if it's star or if it's a co-responder, right? If there's any mental health or behavioral health component, we really want to send someone out to you so you get the appropriate response. And we don't want you to feel extra pressure when you're in that situation to make that call yourself. If you know it's really resource-based, if you've worked with STAR before and you kind of understand how we work, call the STAR line. Even if you're not sure, call the STAR line. They can always transfer it to co-responders. And I will happily put those phone numbers in the chat so everyone can utilize that. And then remind me your second question. I'm so sorry.
So just if you're this is a great recommendation for Denver, and sometimes I'm giving this presentation somewhere outside of it and they're like, hey, what do I do? Do you know of any good resources to recommend to folks who aren't in Denver and maybe don't have the STAR program available?
Absolutely. So WellPower actually runs a STAR program in Arvada. Little fun fact. So we have expanded our STAR program into Arvada. They work with Arvada Fire. So anywhere where Arvada Fire responds to, our STAR van will respond to. Colorado is really on the precipice of change in terms of providing mental health support to people who are in crisis. And most metro area cities, and actually most places in Colorado, have at minimum a co-responder program. Each co-responder program looks different because we want to make sure that we're creating a program that's best for the community that it's serving. But I would say if you're outside of Denver, ask your community mental health agency, ask your, a lot of co-responders are historically involved with police. So ask your local police department if they have a co-responder program. If you're not sure, reach out to me directly. I have a large list of everyone in the state who's a co-responder, and I'm happy to share that resource and how to access them to anyone who has questions. But Colorado is, we attend conferences each year that are international for co-responder, and Colorado always has the strongest presence because we really understand that we need to provide, again, the right service at the right time. And we really are trying to affect that change in the state. So typically you'll at least have a mental health response wherever you are.
That's awesome. Thank you so much for sharing. I think a lot of people don't know that offhand. And so great to know. And please do send that resource list to us as well. And then when we send the follow-up email to everyone who attended, we can include any resources you would like folks to have. One follow-up question just sort of for everyone is, so we saw in the data presentation, the actual facts and data, but we work with a lot of myths and misconceptions in our field. There's a misconception that everyone who's experiencing homelessness has a mental health condition, or that people are just becoming unhoused solely due to mental health conditions. This is questions for anyone to talk about, why do you think this misconception persists and what the reality is?
Well, I can say something to that. There's a misconception there, but usually the way we frame it is that if part of our experience of mental well-being stems from the fact that we know where we're going to sleep tonight. And when that is kicked out as a pillar of our well-being, then we are experiencing a mental health condition. Even if it has not been diagnosed as such, it is distressing and renders all other problems dramatically more irresolvable. So.
I think to add to that,
oh, sorry, go ahead, Tony.
I think to add to that as well, it kind of, once you are in that stress state, that distressed state, it kind of adds to the barriers that you will face in accessing those resources. So it kind of creates that cycle where you may not be suffering from any mental health symptoms right now, but maybe down the road in that cycle you will be.
And Tony, I don't want you to give you work with clients, and I wouldn't want you to give away anything that's specific to a client, but like one of the interesting things about the folks at Renaissance Legacy Lawson in the SIPR program is those people were generally experiencing chronic homelessness and were moved in late 2022, I believe. So we're looking at over like a year of folks being housed, and you're working with those clients over this time. And you've been there since we opened, right? Have you had any experiences of like even people sort of what it was like when they were first housed versus like now settling in a little more? Is that something that you think has really that thing that Vincent's talking about of what it is to be unhoused and how that affects your mental health, but even early housed when you first get into housing versus once you've had like a year to settle in?
Definitely. And I mean, I think that just years, most of our clients have been living on the streets for well over 10 years. And just think of one particular client, just seeing the change and the kind of stabilization over these past 2 years, it's been absolutely amazing. And just as I was saying before, kind of having to go into the hospital about 6 times before in the last 2 years before randomization into our program, you really see like significant mental health issues right when they're randomized and taken into our program. And then just seeing that change over these past 2 years has really been amazing. So yeah, there's definitely that stabilization.
Josie, I also put you on the spot. Once again, we pre-plan questions, but sometimes I wild out, so I apologize. But I mean, at the Stout Street Health Center, we're seeing 17,000 people a year. And you're seeing people who are housed with us at CCH, people who may be housed but sort of on the precipice of homelessness and therefore qualify for our services, and people who are actively experiencing unsheltered homelessness or sheltered homelessness. Do you find differences in how the experience of houselessness is affecting different clients that you serve, or is it all just dependent on personal experience of that person?
Yeah, I mean, it's really hard to try to stabilize someone that's a rough sleeper, someone that is actively outside and sleeping. Sometimes I feel like I'm chasing my tail because it's difficult. And then there are patients that I've had that I've been seeing for a number of years where I'm trying to do that, and then they finally get housed, and I see things settle down like in a really remarkable way. So yeah, sometimes it can be pretty dramatic. But we have at least started to get better shelter options where sometimes I can even patients can get stabilized if they're in a situation where there's just, they know where they're sleeping that night, they know where they're getting their food. I mean, all that can kind of make a difference. But yeah, I mean, it affects their symptoms, and it affects whether or not, treatment, how effective it's going to be.
Thank you. I think we're also sort of walking around talking about trauma, but we're talking about the active trauma of experiencing homelessness in the present and how you can't really work on secondary needs when you're actively experiencing trauma. But there's also, we talk about childhood trauma. We talk about other kinds of trauma that people experience while experiencing homelessness, whether sheltered or unsheltered, more likelihood of violence and assault, more likelihood of police interactions, all sorts of things. If anybody wants to answer generally sort of how trauma plays a role in mental health and why it's important to use trauma-informed care and the work that we're all doing with clients directly.
Sure, I can kind of start to answer that. So I think one of the main things that you see with trauma can be avoidance. And then that it can perpetuate this cycle where there can be sometimes even an avoidance of care. That can be an avoidance of wanting to come in and ask for help because the idea of coming into the clinic might be too stressful. Or the idea of trying to go and apply for that job is just overwhelming. So I think that understanding that, all of our clients have different situations, but that, their experiences are affecting them. I think lending them sometimes sort of like that empathetic approach and that understanding, meeting them where they're at and letting them know that you understand that their past is affecting them today, they can start to feel just a little bit more comfortable with you. So I think that we have to understand that people are coming from difficult situations when we're working with them. And then I think also the other side of that is, besides just the psychoeducation piece of, you're feeling this way because of this, and putting a name to it can be important, but also what we can do in terms of like installation of hope. So that's a big thing in what we're doing in our interactions with people is we see people get better people can get better, and kind of being that person saying that when they're not thinking that and no one else is saying that can be pretty powerful.
I'd also love to add to that. A lot of people that we're working with in the crisis response field are people who've experienced systemic trauma too, and just the trauma associated with accessing care and how they haven't received the care that's best for them. They have felt slighted in their care. There's historical trauma, there's cultural trauma, right? There's a lot of trauma associated on an individual level, and then there's also that broader trauma that people experience. And so, one thing that we have to do is, one, we really need to recognize what state we're responding in. I think as crisis responders, we have to recognize the privilege and power that we have when we show up to someone's door and be able to build that bridge initially to create trust. And that rapport creates trust. We're part of the system, right? We're mental health responders. And so we need to create trust with the system. And we need to say that we respect your trauma, we hear your trauma. It might not be our trauma, but we need to show up and figure out how we can best support you in the moment and what's the best resource for you, right? In social work, we don't say this is what a community needs or this is what a person needs. We ask them first, and then we respond to that. And that's really our path, especially as we deal with people who have individualized systemic trauma, and really trying to build that bridge from the crisis response to getting them into that door.
Awesome. Thank you. Vincent, I wanted to go back to you and ask about follow-up on maybe some specific legislation. This session, I know session just ended. I know we're working on our legislative wrap and going to have a session on that on May 29th. But are there any specific things, Vincent, that you all did during this session, or more about sort of the systems of that allow people some resources that they may not know about?
Well, a couple of things to mention. So one of the things that I think is a contributor to the prevalence of unmet mental health needs among the unhoused population is the lack of access to long-term inpatient psychiatric care, and what's known as the IMD exclusion, which has limitations on the amount of time somebody can be reimbursed for their care, can be reimbursed in certain clinical settings. And that has been limited for Medicaid enrollees to 15 days in some settings, which means that if someone is kept in that setting and not discharged promptly at the end of the 15th day, none of the 15 days of care are reimbursable, which puts care provider organizations in the position of discharging people in advance of the 15th day to be sure that it's all billable, but regardless of somebody's stability or health condition. And so one of the things that we've been advocating for, which has succeeded, is getting the state to request a waiver from Medicaid that will allow billable care up to 60 days. And that should have an impact on some portion of the population, insofar is that once admitted, they'll be able to be cared for until they arrive at a greater degree of stabilization before they are discharged again, because that short-term limitation means that people can tend to cycle in and out of aspects of the system because they're discharged prematurely in order to meet the restrictions around reimbursable care. So that's something that we may see as impactful in coming years if the waiver request is granted by the federal government. One more thing to mention, we were excited about the passage of House Bill 1355, which is for competency diversion programs. As you may know, the state is in distress when it comes to the volume of population that is hung up in county jails awaiting, they're stalled out in their judicial process, sometimes for pretty minor charges. because they are deemed incompetent to proceed with their judicial process, and the state's ability to get people restored to competency as it's described and then back into the judicial process is extremely delayed. And so this bill will create broader avenues and pathways to outpatient restoration or dismissal of charges in favor of access to care. And so we're hopefully that this may have an impact on hundreds of Coloradans that are otherwise hung up in jail as they await the backlog for competency restoration to diminish.
Thanks so much for sharing that. Andrew did put a link in the chat to more about 1355. And yeah, people are waiting in jail for months, even on a really small charge because of this competency issue. And so I know a lot of folks got together for this bill.
Yeah, and one of the drivers of that competency population, is that first responders or law enforcement particularly may be well-intentioned when they're intervening with somebody in crisis, and find that in many communities around the state, there's not a ready alternative for someone who's experiencing homelessness and is in crisis. And so jail becomes a kind of default pathway for not just leaving somebody in place in some unsafe setting. And that's another giant missing piece, is having that, I know Denver does fairly exemplary work on a national scale with regard to the STAR program and alternatives to incarceration, but that's generally not the case in communities around the country, is having that kind of ready alternative placement for folks.
Thank you so much. So I want to talk a little bit about resources. We have one question in the Q&A about local resources specific to Aurora. And we also just wanted to generally ask about resources, like when you're looking, whether it's for an individual for themselves or for a family member, what are the resources that you all like to provide? What organizations do you recommend that folks get connected with? And that question's for everyone.
I think, obviously I work for WellPower, right? So WellPower is an organization that we of course refer to, but I think it's important to note that, again, it depends on the situation and the person's needs in that moment, right? And so it's, we partner with CCH a lot, we partner with Denver Health a lot, right? Like we have resources within our, toolkit or toolbox that we utilize all the time. And it's important, I think, especially in a crisis setting, to be really creative about the resources you're providing, right? Because it might be a situation that's unique, that maybe you haven't worked with, and to do the research and have your due diligence to search for that resource if we can find it, and if not, find other community members that may know that resource. So we'll be if it's important for you to have a resource that's religiously focused, we want to find you that resource for you. If it's important to have case management from a mental health lens, maybe WellPower is the resource for you, right? And so although we have this large list of resources that we utilize and agencies that we partner with often, I think it's, again, important to note that it's about what someone needs in that moment and what resource is going to provide them the best safety, security, and stability that works for them.
I think that's so important to kind of echo. There's no real cookie cutter resource or way to handle a crisis. And I think that really, tapping into the resources that you already have, WellPower, CCH, and kind of seeing the resources that they have like available at those organizations, and kind of, really relaying the information of that crisis or that particular need to get, really creative, kind of just echoing what Samantha said.
I'll also just mention that, Stout Street Health Center is a federally qualified health center. So there should be in about any community. We have statewide meetings regularly with other folks. So, community health centers are designed to be for folks who might not have resource or might not have insurance to be able to have somewhere to go. So you can look up a list of community health centers, and there are many that have, cultural competencies. We are, because of our relationships with Medicaid and everything, if you come to CCH or any community health center, they should be able to do translation services for different languages. So just putting that on folks' radars. Usually if you're looking up a community health center, community clinic, they're one of these sort of federally qualified community health centers. Josie, I think you're muted.
Two places I want to add is I recently went over and did a tour of Denver Cares because I was referring patients there sometimes, and I just wanted to know what it was like, and I was really impressed. And that's it's right near downtown, and it's open 24 hours a day. People can walk in, and from what I'm told, they're very rarely ever turned away. So if people are looking for detox services, that's a great place to go. And they are very invested in getting people into transitional care. So it's not just about going there and getting detox for 48 hours and then you're sent on your way or whatever. They will work with you to get you into a longer term care. So I think that's a great option. And then also through the coalition, we do have Fort Lyons, which is a long-term kind of like a sober living program. People stay there for up to 2 years. It's a really great option that a lot of people in the community don't know about. And I'd also like to answer Barbara's question that she put in the chat, if that's okay. It looked like, is that okay?
Yeah, will you or do you mind if I just read sort of the
Please
gist of
read
it
it.
so that everyone knows who's So Barbara wants to know how people get connected with our programs. She says that her son is falling into homelessness in Denver and has fallen back into drug use and experiencing some other mental health issues, and she's struggling to connect him with help. So she wants to and he's also had some jail experiences, and so she wants to know how to really connect with Wellpower, with CCH, with any other resource that she might have for her son.
Yeah, so thank you for asking this. My heart goes out to you. I mean, we all have people that we care about that are in similar situations to this. So what I would say to you is that please walk into the Stout Street. Please walk in. Monday through Friday, we do have walk-ins every day. I'm there tomorrow, 8 to 4. Generally, half of the people I see are same-day visits. You're right that sometimes if you're calling and you're trying to get a pre-book somewhere or you're trying to make an appointment, they often make those several weeks out. Not every place offers these same day resources. We do. So I would encourage you to do that so we can get some care for your son.
Thank you. One of the questions, this is sort of a big question. We know it's a bit of a silly question, but we do it anyway. If you had a magic wand, what would you do to assist this crisis? This could be like a law or something that changes people. We know that broad substantive changes are what's going to work, but if you could do something, if you could make a change, what do you think you would change? And that's for everyone.
Well, I'll say something about that because we talk about it a lot, and this month is Mental Health Awareness Month, so we've been running a little historical retrospective about mental health access to care and advocacy over the course of the last 50 years in the state of Colorado. And it's sad but true when you look back at the way things are represented in newspaper clippings from the 50s. The language is slightly different in terms of the way we talk about people and our approaches to talking about people have improved. But the needs are very similar in terms of lack of access to settings like permanent supportive housing, to use a specific term to describe something that is more inclusive than that. And there's ebbs and flows of enthusiasm with regard to policymaking over history, where the urgency of need for access to care is addressed and some little progress is made. And then the policymakers seem to forget about it for a spell of time. And then what I think happens is that the state's population grows. And so the need comes to the fore again for the policymakers. They take a few incremental steps and then get distracted by fracking or water rights or something else. And then the population grows and the need surges. And then the policy making kicks in again. And so I think that in terms of waving a magic wand, I think the human community needs to understand that prevalence of serious mental health need is going to be a constant across a human population. It's never going away. It is part of our identity as a creature. And so a responsible community ought to be proactively building out capacity to accommodate an adequate representative number of the population that at any given time is going to need more intensive supportive care. And we always just we can't get to a place where we accept that this is part of our identity as a creature and always act surprised that we have people who have mental health needs that make it impossible for them to maintain a home and stability in a home. And I think we need to learn something about ourselves as a creature.
I think that's super important. I think something that just if I had magic wand, it would be, I think willpower, and like CCH is so good at this, just working in the field directly and kind of seeing this every day, just collaborating with other entities and outside resources. And I kind of, if I had a magic wand, it would just be that all outside providers and all outside entities kind of have that understanding and have that willingness to collaborate. I feel like sometimes we're fighting harder against the systems for our clients than they're willing to, because it's frustrating and it knocks you down, and it takes a lot of energy to get simple things done. And just more understanding and more kind of flexibility with outside providers and just all of the resources that we use.
This can be kind of controversial, but I think that in terms of mental health care, when things were deinstitutionalized, I think overall that was a good thing, because I don't think people should be locked up and put away and not seen in society anymore because they're mentally ill. But I think that we've gone too far away from that, and we don't have like any long-term care options, or long-term substance use facilities are hard to find as well. And I think that we need to recognize for a certain subset of our patients that are severely and persistently ill, they need those services. They need to be in places where there's structure and there's care. And if they're not, they do end up on the street. So I think that there's needs to be more of a medium with that, where people have rights and and we are still advocating for people, but they have that option of safe long-term places to go where people can take care of them, like our society's most vulnerable.
Ditto what everyone else said. So I wish I had 4 magical wands. But I think one thing that we see in the crisis world a lot is for those individuals that need a lot of supportive care, there's not as much emergency shelter support, and it's for specific populations like people who can't perform their own ADLs, that we need some more emergency shelter support around, or people who have been 86'd from other shelters because of behavioral concerns, right? So ultimately it's housing. And I would like to wave my magic wand and provide more housing, and with that housing, supportive services for individuals that are across the whole spectrum, whether it's physical care that needs to be supported, mental health care that needs to be supported, dual diagnosis, substance use, mental health combined, people with IDD diagnosis, but just wraparound services in-house and housing for those individuals, emergency and long-term.
Thank you so much. If I had 4 magic wands, I would give them to you all. Yeah, I think Samantha, your point's well taken. And I think, we often do these ed series and we end up always where we think we're going to end up, which is that housing first, but not housing only is the solution. You give people housing, you give them wraparound services, and these things tend to work themselves out, because the process of being unhoused is very traumatizing, and people need a safe place to be. So we do all these ed series, and often we try not to get too in the weeds about housing and affordable housing, and then we always come back to that in some way, shape, or form. You touched on this a little, Samantha, but we did have a question also from Paul in our Q&A about homeless shelters having mental health resources. Are those available, or are 911 or 988 their only resources? If you don't mind, before you answer, Samantha, I'm just going to give a quick response that at the Denver Rescue Mission, we do have the 48th Avenue Health Clinic, which is a satellite of the Stout Street Health Center. And so we have added that at that one shelter in town. Now, that doesn't mean that that's happening everywhere. It does have limited behavioral and mental health compared to the physical health on that site. But it does allow people who are staying at Denver Rescue Mission the opportunity to establish care, to get their prescriptions on site and things like that. And I will say that some of the understanding, I think, for funding for having these types of resources inside shelters really did happen around the COVID-19 crisis. And when we built these large shelters, realizing that you needed to have healthcare integrated with housing, it was one of the few positive side effects of the COVID crisis was people seeing that that's a model that needs to happen, is healthcare meeting people where they're at. And so we do have that at the 48th Avenue Health Center, which is part of Denver Rescue Mission. But I think that hopefully Samantha and perhaps others can better answer generally how this works at shelters.
Yeah, and just for sake of transparency, I have not been a responder in the community for quite some time, so things may have changed that I'm just not up to speed on. But from my understanding, there is at least a social worker in a lot of our emergency shelters that can at least connect someone, whether there's like direct providers in those shelters. That might be stuff that I'm just not acutely aware of, just being, changing roles over the past few years. We also have someone at the Denver Rescue Mission that provides intake and access to well power once a week. So we are trying to establish some other care in those shelters where people are staying, are sleeping safely for the night, and need to be connected to additional support. In terms of crisis lines, you can of course call STAR, and they can connect you with a list of resources. They're way more knowledgeable about community resources than I am at this point. There's 988, which is our suicide hotline, a national suicide hotline. There's the veterans line. There's also the Colorado crisis line. They have a wealth of information. It's 24/7, free of charge, and they also have access to a ton of resources. There's 211 that has access to resources, and then there's also walk-in centers throughout the state. Walk-in centers are for any self-identified crisis for individuals, and we see people. We run the Denver Walk-in Center, which is at 4353 East Colfax. I can put that in the info sheet as well. But it's for any aged individual 24/7 who, again, walks in with a self-identified crisis. And sometimes people's crisis is, I don't know where to access food, right? And so we will gather a list of resources for individuals. It's, to make sure that we can give them safe and supportive services so that they can get out of said crisis and move towards stability. So plenty of resources in the Denver community. And I would say those are our top areas and top phone numbers to call to access.
And the 48th Street Clinic, from what I understand, I think it is Denver's largest shelter, the 48th Street. It's a men's shelter, but there is a women's shelter not far away. That the Coalition for the Homeless actually does have a clinic within it that's staffed by coalition staff, and there's usually a medical assistant, there's a nurse, and there's medical providers there that they're equipped to kind of start and triage mental health disorders, and then we get a lot of referrals for them. So I do see a lot of patients that are from the shelter that they're connecting to me. And then I do know, I'm pretty excited about, starting in July, we're going to have a therapist going out there that's also going to be seeing clients. So we're trying to kind of increase our access out there.
Glad that's happening. Mike Massey over at 48th mentioned that there was going to be someone, but I didn't know it was in July. So that's great that that's happening. Awesome. All right. Well, I don't have anything else in the Q&A. If anybody, I think this is just a chance if anyone has anything else that they want to add, any panelists that have anything to add, and don't force it if you don't, it's totally okay. And then we'll go ahead and wrap up. But if there's anything you think we missed, anything you think folks want to know, please join in. Okay. I love it. If means we had a good panel if we don't have any more questions at the end. So yeah, Gabriella, if you can put up the slides, we'll just go ahead and wrap today. Just want to first thank everyone for coming. First of all, our amazing panelists, thank you so much. I think we covered so much ground in a really short period of time, and just really appreciate you all taking the time and explaining things so well. We are going to compile these resources and put those out to folks in our wrap email, so be on the lookout for that. Thank you to the team who helps do this every month. It's not just me, it's a bunch of people working behind the scenes. So thank you, Shannon, Gabriella, Andrew, and the other team members who aren't here tonight. And then, of course, thank you all for coming. We know that this is a particular choice to spend your Thursday night with us. And so to be able to take the time and learn more about this subject, thank you all so much for really making time for that. We will not have a session in June, but we will be back in July. And we're going to talk about economics of homelessness. We're going to talk about the Denver Basic Income Project. We're going to talk about benefits. So please join us for that one. And yeah, thank you all so much for coming out tonight. If we didn't get to your question in the chat, that I apologize. There was a really specific question about Pueblo and we didn't have an answer. I checked in. So we can try to follow up with you after the fact on that one, Jimmy. And then, yes, sorry, thank you. We have our legislative wrap on Wednesday, May 29th at 5 p.m. So if you want to hear about some of the legislation that happened this session, 1355 and other things that happen in homelessness, health, economics, the main areas that we work in, please do join us on May 29th for that. And we'll include that in that wrap email as well. So thank you all so much and we'll see you next time.